Hello, everyone, and welcome to Veterans and Parkinson's Managing Cognitive Changes. I'm Sarah Osborne. I'm the Associate Director of Community Programs with the Parkinsons Foundation. And here with me today are my wonderful colleagues, Kayla Mead, many of you met in back, Lauren Williamson, and Bernice Deddick. So first, I'd like to thank all of the veterans for the sacrifices that you and your family have made in service to our country. And thank you to those with Parkinson's, care partners, healthcare providers, and everyone joining us here today, both in person and online. We appreciate you and we're so glad you're here. I'd also like to thank Dr. Megan Gomez, who we'll hear from shortly, Lori Guion, the Office of Supervisor Janice Hahn, and the City of Paramount for their generous assistance with the venue and with the promotion of this event. So thank you all so very much. And I also want to say a quick hello to the San Francisco Veterans Affairs Parkinson Center. Annie and Elizabeth and the whole team there are watching with another party just like this. So hi to all of them. Okay, more gratitude. Our local sponsors help to make our events possible. So thank you to silver sponsors, Boston Scientific and Supernus, and to bronze sponsors, Accorda and Abbott. You can learn more about them obviously here today, right? Or at the link that we'll share in the chat. So a little bit about the Parkinsons Foundation. Our mission is to make lives better for people living with Parkinson's today until there's a tomorrow without the disease. And we fulfill our mission through what we call our 3 pillars, which are better care, research, and education and advocacy. So we provide free resources, including our website, which is parkinson.org, our educational book series, webinars, of course, podcasts, a hospital safety kit, which is called Aware and Care, our newly diagnosed materials, and our toll-free helpline, which is 1-800-4PD-INFO. We also have a veterans webpage at parkinson.org/veterans, which includes information and resources like our FAQs for Veterans booklet. So our newest research project is called PD Generation, and this is a no-cost, at-home genetics test for people with a confirmed PD diagnosis. And you'll see the website there, parkinson.org/PD Generation, or you can take one of our cards from the table here today. Right now, we're also a research partner in a project called Topaz, which studies bone fracture prevention, and you can call us at that 1-800 number if you'd like to learn more about that study. Okay, and we hope that you'll stay connected with us on our website, social media channels, by phone, email. We have lots of ways to connect. We do have a fun event coming up in Los Angeles and actually all over the nation on February 25th. These are our stationary cycling events. We all know how important exercise is. They're called Parkinsons Revolution, and they bring the community together for fun and fundraising for our important mission work. And we invite you to learn more at parkinson.org/revolution. Okay, a few housekeeping items. We encourage you to submit your questions at any point throughout the program. So you can write those questions on the index cards if you're here in person. They're right in the center of your table. Or we have the Q&A and chat functions enabled on our webinar. So you can use that as well. We're going to organize those questions and we will ask them after the presentations. And we also want to let everyone know that we're recording the webinar and we'll post it on our YouTube channel, and we're going to share the link in an email after the event. We have a wonderful program lined up for you today. We are going to talk about cognitive changes, but we probably won't start with a Parkinson's basics. If you want a little bit more about that, you can visit our YouTube channel. Okay. And now I am happy to introduce our guest speaker today, Megan E. Gomez. Dr. Megan Gomez is a clinical psychologist working at the Tibor Rubin Medical Center, Veteran Affairs, Long Beach Healthcare System in the home-based primary care program. She provides clinical psychology services to veterans enrolled in the program and their caregivers, and facilitates the Parkinson's support group at the VA of Long Beach. Her research interests include cognitive health in older adults and improving the quality of life for people with Parkinson's disease. Welcome.
Hello, everybody. Thank you so much for joining us. We have a nice audience here in person, and then we have over 500 people joining us virtually. People ask me, do you get nervous when you're giving these types of presentations? And I honestly don't, because the Parkinson's community is so kind and welcoming, and I feel like I'm talking to family. People who have Parkinson's, I feel like we just get each other. If you understand Parkinson's, the best thing is not having to explain it to anyone. If you walk into a room of people with Parkinson's, it feels like you're coming home, where you can just be yourself. And I love that. So I'm super excited to join you today. I am going to start my timer because this is a topic that I could talk months about. So I know we have a limited amount of time, and there's a lot that I want to cover. So let's go ahead and get started. Oops. Let's see. Okay, so first I wanted to start with my disclaimers. So I am a clinical psychologist. I'm not a neurologist and I'm not a psychiatrist, and that was by design. So when you see your neurologist or when you see your psychiatrist, you know, sometimes you see them every 6 months, maybe if you're lucky, every 3 months. As a psychologist, what drew me to the profession was that I get to see my patients every week. And rather than spending 15 minutes with them and rushing through the appointment and having back-to-back patients, I love the fact that I get to spend at least an hour with my patients. So as a psychologist, I don't prescribe medications. I am my tool. It's about me connecting with you, hearing about what's going on with you, and I get to see you frequently, which I love. No financial disclosures to report. I'm not getting paid to be here or to talk to you, but I always feel like I'm getting paid in a more meaningful way by getting to meet you and to hear your stories and to hopefully provide you with hope. I like to joke that I'm a hope dealer as opposed to a dope dealer. I like to instill hope to keep going. Parkinson's is hard. I'm not going to lie. I'm not going to sugarcoat it. But I feel like this community that we have is so powerful. So I feel like there's always so much hope to glean from these types of talks. Finally, my professional opinions are based on research and my clinical practice. They're not necessarily something that the VA endorses or the Parkinsons Foundation endorses, but this is what I have come to learn from my studying and from working with hundreds and hundreds of people with Parkinson's and their families. All right, so a little bit about me. I grew up here in the city of Paramount. For some of you who are here in person, this may be your first time actually being in this small city nestled in between Long Beach and Compton. But it's so special to get to have this event here in the city of Paramount. A little bit of my family history. So my grandfather and his siblings lived in Paramount. My mom was born and raised in Paramount, and I grew up in Paramount. Family has been a central part of my life. And when I was 14, my grandfather was diagnosed with Parkinson's. So I was in my freshman year of high school and had no idea what Parkinson's was. And yet my beloved grandfather, who was my best friend, had this diagnosis given to him. And so throughout high school, he and I kind of learned about Parkinson's, and I to learn a lot about the brain. And I knew that I wanted to become a psychologist at that point. But it wasn't until my grandfather was diagnosed with Parkinson's that I realized I want to work with this population. These people are so resilient, so funny, and have so much internal fortitude that I was so inspired getting to see the way my grandfather tackled his Parkinson's. And I did undergrad at USC. And I got to work in the neurology department there, where I really got to learn more about what Parkinson's was and how different it is for every single person. So my grandfather's Parkinson's often looked very different than the people that I was seeing in the clinic. And the complexity of Parkinson's is what really drew me in, like seeing how it's like an onion. The more you learn about Parkinson's, the more you realize I don't know anything about Parkinson's because it's so complex. These slides. All right. Oops. Okay, so I have a master's degree in psychology and theology, and I really wanted that theology degree because there's so many existential questions that come up when you have Parkinson's. Why are bad things happening to good people? Why would God let this happen to me? A lot of meaning of life questions and kind of identity questions. Who am I if I'm not that high achieving, productive person? That now, rather than being able to fix things on my own, I have to hire someone to do it. Rather than being the master of my craft, it takes me so much longer to do what I used to be able to do so easily. So I knew that in working with people with Parkinson's and chronic illness, that understanding of how people have their faith and how these sorts of life-altering conditions can impact our sense of ourselves, our sense of the world, our sense of God. And then I ended up getting my PhD in clinical psychology. So a couple of places that I worked at, USC, I mentioned I worked there as an undergraduate. I also completed my postdoctoral training in the Department of Neurology, completing neuropsychological assessments for people that have Parkinson's. I also worked at Cedars-Sinai, which is in Los Angeles. Also Rancho Los Amigos, which is here in Downey, in the rehabilitation hospital. So people that had strokes, people that had a variety of medical conditions that needed different types of therapy, physical therapy, occupational therapy, speech therapy. I also went to the dark side and went to UCLA. And I finished at the VA Long Beach, which is where I am now. So throughout my training, I really tried to go to the institutions that I could take away from each of these different places and learn different aspects about Parkinson's. When I eventually landed at the VA Long Beach, I realized that there was a major need for Parkinson's specific resources. Having been at these other institutions where they had a lot of different programs for Parkinson's, I felt like we really needed to bolster that at the VA. So in 2016, I created the Parkinsons Support Group, which is near and dear to my heart. And you'll get to actually see from videos from two of the veterans who participate in that group. And then I also work in the home-based primary care program. So I get to go into veterans' homes and provide psychological services to them in the home. And I recommend all of my patients with Parkinson's consider this program, because rather than having to fight traffic and parking and navigate to the clinic, you have a whole team of specialists that come into the home. And the number of patients that the providers see in the home-based primary care, rather than 1,000 patients that the primary care providers see in the outpatient clinic, they see 90 people in the home-based primary care program. So the level of care and attention and familiarity that you get is a whole nother level. And you get to see the person in their environment where they're most comfortable. You get to see what's working well in the home and what can be improved. You get to meet their families and see the dynamics. So it's very rewarding work, and I really feel honored that I'm in that program. All right, so here's our outline for today. First, I need to talk about non-motor symptoms of Parkinson's. We all know what Parkinson's looks like visibly, but there are so many things that are invisible. And as a psychologist, those are the aspects that I focus on. Next, we'll talk about what is cognition, how is cognitive impairment in Parkinson's different than other conditions. We'll briefly talk about how to prevent or slow down cognitive decline, and then we'll wrap up talking about treatment of cognitive impairment and compensatory strategies. So let's talk a little bit about non-motor symptoms. As I mentioned, those motor symptoms are the things that we see, right? We see a movement disorder specialist. The medications we take for Parkinson's are aimed at improving those motor symptoms. But we all know that those non-motor symptoms, the ones that we can't see, can oftentimes be equally or more so disturbing and disruptive for not only the person with Parkinson's, but their loved ones. So let's talk a little bit about, go back. Okay. Oh, let's see. Go back one. Okay, there we go. So we like to think of the Parkinson's iceberg, with the tip of the iceberg being the rigidity, the tremor, the slowness, the stiffness, the postural instability. And then underneath the iceberg is all of those non-motor symptoms. So this is what I work with my patients one-on-one. The constipation, the speech. Your speech oftentimes becomes softer and less articulate. The anxiety, the panic attacks. Just like some people have the tremor on the outside, sometimes they can feel a tremor on the inside. The lack of facial expression, the impulse control, we can go on and on, the sexual problems, the hallucinations. Today, we're going to talk about cognitive impairment, of course. All right, so some of the non-motor symptoms are a pure result of the brain changes occurring with Parkinson's disease. And some of the non-motor symptoms are a side effect of the medications used to treat Parkinson's. So it can be very difficult to understand what's causing my particular symptom. Is it occurring within my body? Is it a result of the medication I'm taking? And many of you know that sometimes it can feel like once you get a handle on one symptom of Parkinson's, another one pops up. And so it requires a lot of flexibility, right? A lot of taking it one day at a time. And I know Parkinson's can feel so overwhelming and so daunting, but I love to work with my patients to let's focus on just one thing. What's the most disturbing symptom that you're experiencing today? And let's focus on that. All right. Of course, we know that there's different types of Parkinson's. There's lots of different umbrella symptoms of Parkinson's. But let's jump into what is cognition. When we think about cognition, go back. Let's see. Okay, please. There we go. When we talk about cognition, and I ask, what is cognition? A lot of people say memory, and that's true. Memory is one part of cognition. When we assess a person's cognitive abilities, we are looking at all of these different cognitive domains. So at the top, we have attention. How well is somebody able to focus and attend to what I'm saying without being distracted by the person talking next to you, by your lunch date that you have to get to after this, by wondering or listening to the rain outside? Another cognitive domain is information processing speed. How quickly am I able to take in and synthesize the information that's coming at me? Either verbal information, sensory information. We know that people with Parkinson's tend to slow down with their motor functioning. They also tend to slow down with their cognitive processing. So it may take them a little bit longer when you ask them a question to be able to formulate their response and say it. It may also feel like everything's happening very quickly, like a conversation is happening so fast that by the time they can come up with what they want to interject into the conversation, it may feel like the conversation has already moved away in another direction, and they never had that chance to give their 2 cents. So a lot of times people can misperceive that as this person isn't interested, or this person isn't wanting to engage in the conversation. And a lot of times it's just because it's happening so fast. Language is another cognitive domain. So language can be receptive language, being able to comprehend and decode what you're hearing or what you're reading. And we know that sometimes when we're reading information, we may have to read it 2 or 3 times to actually get that comprehension. Expressive language is that ability to articulate ourselves, either verbally or through written information. And a lot of people will tell me, I'm not as articulate as I used to be. I know the word that I want to say, it's on the tip of my tongue and I can't get it out. So we're going to talk about that ability to access the information when we want it and be able to get it out and in an expressive way. Visual spatial functioning, that's being able to navigate from point A to point B. So you guys traveled from your home to get here today. You navigated from your bed to the kitchen. Visual spatial functioning also includes depth perception. So how far am I from the next step? How quickly are the cars traveling? So really being able to know where we are and how our environment is interacting. Executive functioning, that's my favorite one. That's that frontal lobe right here. And that's sort of the CEO of the brain. That is responsible for planning ahead, using good judgment, being able to problem solve. For example, some of you who drove here today may have been cut off. Executive functioning helps us decide, am I going to give that person the finger and lay on the horn and tail them? Or am I going to give some distance between myself and that car, right? It may be executive functioning when we're having a conversation and somebody brings up a political comment that we don't agree with. Are we going to say, what are you talking about, and disagree politically? Or are we going to say, no, I'm going to use my filter. I'm not going to engage. Learning and memory. So we're constantly learning new information. Short-term memory versus long-term memory. Visual memory, what do people's faces look like, versus auditory memory, what's their name, right? Some of us are good at one or the other, not necessarily both. And then lastly, motor functioning. Motor functioning is a cognitive skill. And we know, of course, that with Parkinson's, that motor functioning can be impacted, right? It's oftentimes the most notable cognitive change that we experience. So yes, memory is a part of cognitive functioning, but it certainly is not all of it. Okay. Let's see. Cognitive functioning over the lifespan. So we are all at our cognitive peak between 25 and 35. And with each passing decade after that, we know that we get a little bit less efficient cognitively. We start to slow down a little bit. This slide here kind of shows that in general, our cognitive abilities do decline with each decade. There are a few cognitive domains that are consistent or actually improve over time. Those are things like wisdom, being able to integrate our life's experiences and make meaning out of them. So normal aging, we expect that gradual decline of functioning over time. When it becomes more significant than normal aging, that would become mild cognitive impairment. When we do neuropsychological testing, we can compare, how did you do compared to your peers, meaning the people the similar age as you with the similar educational and occupational attainment as you. When you're performing worse than your peers, but you're still able to manage your day-to-day life, that would put you in the category of mild cognitive impairment. When you start noticing errors happening, you're mismanaging your finances, you're mismanaging your medication, you aren't able to take care of your household responsibilities due to cognitive impact, not the motor impact. That would be considered major cognitive impairment or dementia. So there's these 3 cognitive classifications. You could be normal aging. Yes, you're slowing down. Yes, you have the occasional word finding problem, but when we do testing on you, you're right where you should be for your age. Versus you're struggling a little bit more, but you're still managing. That would be the mild cognitive impairment, or MCI. And then finally, that last category would be the dementia category. I'm going to see how I am here on time. Okay. All right, so those were the three categories that we talked about. When I say dementia, a lot of people think dementia and Alzheimer's are synonymous. So dementia is an umbrella term, and you can have dementia due to a variety of causes. Alzheimer's disease is a type of dementia. It's the most common type of dementia, but there's also dementia due to Parkinson's disease, due to vascular disease. So if you have high blood pressure, high cholesterol, diabetes, that would be due to the vascular cause. There's also dementia due to Lewy body disease, due to traumatic brain injury, due to substance. The type of dementia that you have is going to dictate the rate of progression. How quickly would we expect your dementia to progress? Would we expect for it to be a slow, steady decline like we would see in an Alzheimer's or Parkinson's, or would it be you're okay, then you decline, then you're okay, then you decline? That's what we would expect to see in vascular type dementia. So the type of dementia is determined based on your history. Let's talk about what kind of lifestyle you had. Let's talk about your health, and that can help us determine the type of dementia you have. So in Alzheimer's disease, that temporal lobe, the blue part of this brain, is impacted. In Parkinson's disease, it's the purple, that frontal lobe is affected. So Alzheimer's disease affects our memory. Parkinson's disease, dementia, affects that frontal lobe. In Alzheimer's disease, it affects a neurotransmitter called acetylcholine. In Parkinson's disease, the neurotransmitter affected is dopamine. Different parts of the brain, different brain chemicals, and different cognitive domains affected. Before we talk about cognitive impairment in Parkinson's disease, we're going to look at a couple videos from two of our veterans who are in the group, and they're going to explain to you from their perspective cognitive impairment.
Okay, I'm Brett Watterson. I served with the Air Force for 26 years.
And how long have you had Parkinson's?
I've had Parkinson's now for 14 years.
Have you noticed any cognitive changes?
Yes, I have. In addition to just being able to perform daily tasks, things like reaching the right word, articulating properly, impulse control issues. I've had severe, well, not severe, but major, seems like impulse control, and judgment is declining. So I don't trust myself to make decisions. I certainly don't trust myself to drive. I don't trust myself to make independent decisions based on financial activity. That's about it.
Yeah. So with some of those changes, it sounds like you're relying more on your wife to help you.
Yes.
With decision making and with finances.
Yes, I am. Ruth has got control of the checkbook. We both have control of the checkbook. And my pay and my disability and my Social Security. So,
what's been the hardest cognitive change for you?
I think judgment. I think decline in judgment.
My name is Tony Adele. I served as a Navy corpsman with the Marine Corps Infantry in Vietnam in 1967. I served with the Marine Corps and the Navy as a hospital corpsman for 4 years, 64 to 68.
And how long have you had Parkinson's?
It's difficult to say, to actually numerically say, but however, I think it's been about 5 or 6 years. The last probably 6 months have been the most deleterious.
Have you noticed any cognitive changes?
Yes, the last 5 or 6 months I've noticed a decline, particularly in my vocabulary, my ability to retrieve words. I have to kind of dumb down my vocabulary. I notice my memory, my concentration, my frontal lobe, my ability to plan, and my inability to multitask. Just a number of cognitive issues that are severely affected.
I think it's always so helpful to hear directly from our veterans what they're experiencing. So thank you to Brett and Tony for sharing their experiences with us. I think next we're gonna do a quick exercise break. You guys wanna do the slides? And we have Gladys here. She's one of my colleagues at the VA. She's a kinesiotherapist and also works in the home-based primary care program.
Okay. Well, thank you so much, Megan, for that first part. Thank you. I'm going to introduce Gladys then, and we'll take a quick break, and then we'll come back for the second part of Megan's presentation and then the Q&A. So Gladys, you received her bachelor's from Long Beach State University in kinesiology with a minor in psychology, in addition to a master's degree in exercise and wellness. She has proudly served the Veterans Administrative Medical Center for over 4 years. She then started an all-female veteran-based wellness class called Women Owning Wellness, and serves patients who are homebound with the home-based primary care department. She's also an active member of the kinesiotherapy department and leads gatherings and team building activities there. So welcome, Gladys.
Okay, thank you all for the introduction. So my name is Gladys, like mentioned. I have been serving our veterans such as yourselves for the past 4 years in Long Beach. I am glad to be here to lead you guys through a guided meditation, guided exercise, as most of these exercises I'm going to show you are geared specifically towards Parkinson's patients. So before we start any exercises, I would like you guys to move your chairs out a little bit further from the table so we can actually move around. And then also have enough space where you can bring your arms out to the sides. Okay, we'll give people a few minutes to just kind of adjust. All right. All right, so just to provide you some information about exercise and its benefits to Parkinson's, it's just like medications. If not, it's just as important as taking your medications daily. So with exercise and Parkinson's, it can help maintain your strength, your flexibility, your balance, as well as your cognitive acuity. It also helps you just perform your activities of daily living to make it a little bit easier, as well as to help you guys do the things that you love to do on a regular basis. Also with exercise, you can slow down the progression of bradykinesia that can be seen as Parkinson's progresses. So the more movement, the better. So let's go ahead and get started. So the first one, I'm going to have you guys sit at the edge of your seats for me, still supported by the chair with your feet flat on the ground. And I want you guys to sit upright with your shoulders back. All right, from here, it's going to be a seated posture exercise. And what you'll do is you're going to have your feet at shoulder width apart. You're going to place your hands on your knees, and then you're going to bend forward at your trunk, trying to get your chest towards your knees. And then you're going to lift up and bring your arms out to your side with your fingers out, okay? So we're gonna do this for a count of 10 on my cue, and I want all of you guys to count out loud with me, okay? So let's go ahead and start. 1, 2, 3, good. 4, 5, 6, 7, 8, 9, 10. All right, how was that? That was okay? All right, so the next one we're gonna do is a seated rotation exercise. So let me show you how it looks, and then we'll go ahead and count together, okay? So we're gonna have our hands out to the sides like this, and we're gonna bring one hand to the other, and as we do this, we're gonna rotate our torso to one direction, and we're gonna look at our hands as we do that. Okay, so that is considered 1. And then we'll be alternating back and forth for a count of 10, okay? So we're gonna start here, and then we're gonna count out loud. 1, 2, 3, and we wanna go at a slower pace, okay? 4, 5, 6, 7, 8, 9, 10. All right. That was okay? All right. So the next one, your legs are still at shoulder width apart. You're going to now be reaching to one direction. And as you reach, you're going to look up towards the hand that is reaching. So look like this. So one side and then to the other, okay? So let's go ahead and count. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. All right. Now we're going to move into the standing exercises. So I'm going to have you guys stand up where you are. You're going to bring the chair to the side of you, and then we're just all going to stand until everyone is ready. And then if you can't do it standing, you can also do it seated if needed. All right. So for this one, we're going to just be raising our foot just as if we're marching, okay? And you have the chair there for support if needed. If you feel like you don't need it, then go ahead and just put your arm down to the side. So let's go ahead. We'll count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Good? All right. So the next one, we're going to stand a little bit further from our chair with our feet at shoulder width apart. We're going to also do another shoulder trunk rotation by bringing your hands out, similar to the one we did seated, but just now standing. And you're going to reach to one side and look in that direction. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. All right, everyone doing good? Yeah? All right, so the next one is also weight shifting, but now we're gonna do it standing this time, and you're gonna be reaching to one side, emphasizing the reach. You don't wanna lean too far forward, but you wanna be able to just reach at a good distance, okay? And then you're gonna be reaching to the other side. All right, let's go ahead and start. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. All right. Are you guys kind of warm? I'm very warm in this jacket, but I don't know about you. Okay. And then last but not least, we're going to do a walking one. So I want you guys to really emphasize the movement of your arms back and forth. So I'll consider this 1, and then we'll count up to 10, okay? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Well, as I just noticed, I only did the arms, but you could also do it with the walking if you have good coordination. So with that being said, these are all exercises that can be performed, whether it be seated or standing. And with kinesiotherapy at the Long Beach VA, we help serve patients with Parkinson's. So if you're ever interested and you're getting care at Long Beach, let your providers know. It was a pleasure to guide you through some exercises through this quick little break. And I hope that you guys continue to move as much as you can, and then just incorporate these exercises as much as possible. Thank you for your time.
All right, so we talked about how the cognitive domain that's most affected in Parkinson's disease is that executive functioning, that frontal lobe. I want to explain a little bit about why that is. So we know that with Parkinson's disease, we have less dopamine in our brain. By the time someone is diagnosed with Parkinson's, they've already lost about 80% of their dopamine. So we are working with much less dopamine in our brain. The medications that we take, the carbidopa, levodopa, that acts as a dopamine replacement, right? So when we take our medications, in theory, it gives us more dopamine. Dopamine is in the brain in 2 main parts. So first, that motor or somatosensory part of the brain. That's the part of the brain that controls our movement, right? Our walking, our writing, all of the motor symptoms. So that part of the brain needs dopamine. When we don't have enough of it, we see the motor symptoms of Parkinson's. The prefrontal cortex also requires dopamine to function correctly. So we see that dopamine is supposed to go into those 2 main parts of the brain. And when we don't have enough, we start seeing some of those symptoms emerge. A lot of the things that that frontal lobe does is it helps things become automatic. We can all remember what it was like to learn how to drive a car. We were tense, we were nervous, we were intimidated by the car and how it functions. We were intimidated by the road and other drivers. We may have been intimidated by our parent who was trying to teach us how to drive. We were very anxious, right? But the more and more you drive, the more you kind of relax, the more you get the hang of it, you sort of get into your groove. It becomes so automatic over time that oftentimes you may park at your destination and say, I don't even know how I got here. I was on autopilot, right? That frontal lobe's job is to turn things into automatic processes. When we have Parkinson's disease, that automaticity goes away. So things that we used to be able to do automatically, like walking, like reading, like being able to drive a car, like being able to get in and out of a chair, we do it without thinking about it until you have Parkinson's disease. Then you're having to consciously think about every step, where you're placing your foot, what obstacles are around you. You're having to think about your arm swing. A lot of these things you never give thought to. So when you have Parkinson's, you may not even consciously be aware that your brain is having to think about each and every step. But oftentimes it leads to you feeling very fatigued. The amount of brain energy that you're having to use in order to do those everyday things it builds up, right? So things that used to be automatic, you didn't have to think about them. They would happen effortlessly, they would happen quickly, and they would happen fluidly. But now you're having to think about those steps. You're having to give conscious attention, and they happen slowly, and they don't happen as fluidly. It feels a little bit more choppy, right? So things like getting in and out of a car, you are thinking about where to hold on. You're thinking about lifting up your foot. You're thinking about repositioning your butt. Each step you have to think about. The same is true for reading. I often share with my group, you may have read novels before, and now you're reading magazines. Reading used to be something that was automatic. You could quickly scan and encode the information. Now it's choppy. It's one word, one word, one word. What was it? Read it again. So nothing is fluid or automatic the way that it used to be. Multitasking, when you're having to concentrate on those day-to-day things like brushing your teeth, being mindful of where the brush is in your mouth, being mindful of all of those things, it makes it really hard to multitask. You're focusing on walking. You can't walk and have a conversation at the same time. Or maybe you've noticed you're driving and you turn off the radio, because driving and listening to the radio at the same time becomes very competing. Your brain can't do both at the same time. Another example of multitasking is if you have the television on and your wife is trying to talk to you. For a lot of people, you're able to block out that distraction and be able to focus on just your wife. But it's that frontal lobe part of the brain that helps you say, hush that sound of the TV, amplify your wife's voice, and focus on it. So remember, we talked about focusing and attending, being able to block out those distractions. That frontal lobe is responsible for all of that. It's also responsible for helping us prioritize. So in this picture, she's trying to write, pay attention to her kid. Her other kid is playing basketball and she's on the phone. That frontal lobe has to prioritize what's most important. What should I focus on first and then second? And it helps us sort of get an organization strategy in place. So executive functioning also helps us, as I mentioned before, pull out what's that actress's name? Ah, yes, Angelina Jolie. What was the name of the TV show we were watching last night? What was the name of the street that our friend lives on? The information is in the brain. Unlike Alzheimer's disease, that information doesn't go away. It's just we have a hard time pulling it out quickly when we want that information. So sometimes I'll get a veteran call me and say, the word I was wanting to think of in this session is whatever it is. Sometimes we know what the word is, but it doesn't come to us quickly. And then we find ourselves racking our brain trying to come up with the word. Another really important aspect of executive functioning is helping us know what's happening in our body. So a lot of times I'll hear from spouses, my husband is constantly getting UTIs. I put the cup of water in front of him and he won't drink it. And I have to explain sometimes that we're not getting the message from our body to our brain to act upon those bodily needs. So sometimes you have to say, here's a cup of water, take a drink, to the person with Parkinson's, because they're not getting that internal cue, I should drink water. Same with eating. If you give them a plate and say, eat that, they may or they may not, but sometimes you have to give them the actual food in their hand and have them eat it. Oftentimes that internal sense of time, we kind of have an idea, like when I'm hitting my 50-minute psychotherapy session, I can gauge, we're at 48 minutes, we're at 49 minutes. That sense of time is an executive functioning part. So sometimes we lose sense of how much time we've been on our computer, or we lose sense of time with how quickly we need to get out of the house to make it to our medical appointment. So sometimes I'll hear wives say, at the last minute, he decides that he needs to go take his medication or that he needs to put on his shoes, but he's had this whole time to get ready and he waited until the last minute. It's that internal sense of time that sometimes goes away. Also, our perception can sometimes be off. The person with Parkinson's may think they're speaking loud and clear, but other people don't see that or hear that. They may also think that they're using big steps when they're walking, when in reality, they're shuffling, right? So we don't oftentimes get the feedback to change what we're doing, to speak more loudly, to move bigger, to that feedback loop sometimes gets interrupted. So we need people to give us those cues, speak up, use bigger strides. And that can cause a lot of conflict within families to feel like you're constantly getting criticized or getting that feedback, but we actually really do need it. But it can be a source of frustration for both parties, the person with Parkinson's and their families. It can be helpful to see a professional therapist, speech therapist, occupational therapist, because then they can give you the feedback. And it doesn't always have to be coming from your family. One of my patients told me, it feels like I have to consciously connect my brain to parts of my body. Like I have to consciously say, move your foot, connect to your foot, connect to the other foot, where you're consciously having to connect your brain to send those signals to your body, which for those of us that don't have Parkinson's, it can be very hard to understand what that would be like. But I think it hopefully elicits empathy within us that they are having to exert so much attention and energy and focus to do the things that we do without even having to think about it. So yes, you're going to need naps. Yes, sometimes your body is going to say, I'm done and I need a break because it's working 2 or 3 times harder than the average person to do those things. Can you change the slide? Okay. Executive functioning helps us feel motivated. It gives us that dopamine, gives us that pep in our step. It gives us the energy to take on the day. For people with Parkinson's, sometimes they wake up and they're depleted. They slept maybe 10 hours, but it wasn't a restful sleep. They had to wake up 3 times to empty their bladder. They were uncomfortable and couldn't rotate their body to get in a comfortable position. They felt rigid in their bed all night. So that motivation, oftentimes your loved one isn't depressed or they aren't lazy. They just don't have that dopamine in the body to get up and get going and to seize the day. Which for veterans, of course, can be a big change when we're used to waking up early and tackling our to-do list and being productive. A big complaint I hear from families is also that lack of initiation. If I don't talk to him, he won't start a conversation with me. If I don't ask him how he's doing, he won't ask me how I'm doing. And that frontal lobe gets us to say, check in with the person next to you. Ask them how they're doing. Put yourself in their shoes. So they're not being a jerk. They just don't have enough dopamine in their brain to initiate the conversations, to give a compliment. They may think you look pretty. They're not going to say it because they're not getting that propel to say, wow, you look so nice. Also activities. They may say, hey, what should we do today? Oftentimes it's their partner who's having to be the social coordinator, who's having to come up with the agenda for the day. They also don't oftentimes check in with loved ones, and it's the empathy that they feel like is missing. Next slide, please. Switching. So I oftentimes hear family members say, my loved one is so stubborn. He wants to do things his way. And even if it doesn't work, he doesn't want to try something new. So switching, that ability to change strategies when solving problems, it can be hard to try to come up with a new idea. That frontal lobe is something that's responsible for trying a new activity, brainstorming. What's another approach? Next slide, please. One of the examples I like to give is this toilet, because a lot of us with Parkinson's experience urinary incontinence, right? I get complaints from wives, he's wetting the bed again, and it's becoming more and more frequent. Okay, what have you tried? Nothing. We're doing the same thing that we've always done. Okay, well, let's try using a diaper. Let's put pads in the diaper. Let's try a condom catheter. Let's try this. And there's so many ideas. But if you leave the person with Parkinson's to come up with a new strategy, they won't. They'll keep doing the same thing over and over again, even though they wet the bed every night. So I think a lot of it you have to remember that initiation to try something new doesn't come from inside. Oftentimes you're having to give the person new ideas, new strategies, new options. Next slide. Organization and time management. We touched upon this a little bit. You have your whole list of things to do. Where do you get started? That is an executive task, being able to come up with a plan of action, and oftentimes being able to be efficient. If you know you're gonna, like, women are so good at this instinctually. I'm gonna go to the kitchen, put the dishwasher on, I'm gonna go past the laundry room, start it, then I'm gonna come into the front room. Whereas men in general, but also people with Parkinson's more so, they're kind of like ping pongs. Like there's no rhyme or reason to their approach. It's not necessarily the most efficient. Next slide. So people with Parkinson's may give up on tasks rather than persevere. They may get distracted or discouraged before completing a task. They need more encouragement to keep going, to stick with it. Challenges will present themselves. Being able to keep at it, even when you feel like it's one step forward and two steps back. That frustration tolerance. A lot of times we see people get so frazzled, and it's that ability, that frontal lobe's ability to say, you know what, it's okay. I'm gonna stay calm and keep going. Sometimes they can't let go of that irritation, and then they just sort of give up, throw up their hands and say, I don't want to do it anymore. So again, that usually we have that internal motivation to keep going. We have that optimism to keep going. We have that desire to see a project get done. And that's all dopamine. That's that frontal lobe's job. So when we don't have that working right, we need the enforcement to come from other people around us, from our therapist. And the more people we can have in our corner, the better, because it's an unrealistic expectation that your partner can do all of that for you, that they can be a constant cheerleader. They can't. They're human beings. They have their own needs, and they get tired, and they need a cheerleader sometimes. Next slide. More insight into cognitive decline. So with Alzheimer's disease, people oftentimes don't have insight or awareness into their cognitive deficits. And sometimes that's easier. With Parkinson's, the awareness is there. A lot of times we know when we're struggling. We know when we're making errors. So it can really take a toll on our self-esteem. Self-perception may be inaccurate though, right? So I hear a lot of times my patients say, I can do it. I can still drive. I can walk. I don't need my cane. I don't need my walker. Their perception of their abilities can sometimes be higher than the reality. And sometimes their partner will say, don't walk without your walker. I've told you that. And they say, I could do it, because they don't have an accurate perception of their challenges. Or a spouse may say, you're not safe to drive. And the person with Parkinson's honestly thinks that they can, because it's that self-monitoring ability that can go awry. We kind of talked about how you can feel like you're hollering, and a person can think you're just talking normally. So there's that misperception of how you think you're doing and what other people are seeing. Next slide. So again, this can oftentimes create a lot of conflict for the person with Parkinson's and those closest to them when there's that mismatch or that discrepancy between how I see myself and how you're viewing me. And it feels like I'm constantly being nagged and told to do these things that I don't think I need to do. Whereas your loved one just wants you to be safe and not fall or not get into a car accident. Next slide. So decision-making or impulsivity, it's that frontal lobe's decision where we all have urges, right? Maybe I should go trim the bush. But that executive functioning says, well, no, why don't you hire the gardener to do it? Or no, my balance isn't that good. I shouldn't climb up the ladder. Or it's getting dark. Maybe I should wait until morning. Sometimes those breaks that say, slow down, hold on, let's think about this. Is this a good idea? It's not operating. So what do? You go get the ladder and you start climbing up it. Or maybe you get a wild hair and think, oh, I'm going to get under my car and see what's going on. So sometimes we have ideas. All of us have really wild ideas. We get very weird thoughts in our head. That frontal lobe's job is to say, that was a really weird thought. I'm going to move on and not think about that again. For someone with Parkinson's, they get a weird thought and they kind of just keep thinking about it and they ruminate and they perseverate and they can't let go of that weird thought. But a lot of times I just have to tell people we all have so many weird thoughts throughout the day. We would never act upon them or do them. And usually we could just say that was weird. Don't think about that. But for someone with Parkinson's, they don't have that ability to say that was a weird thought. They kind of keep going with it and can't get it out of their head. Next slide. Similarly to that, we all need to suppress our urges, right? So some of us, sure, I think about having an affair. Sure, I think about stealing from the store. Sure, I think about what would it be like to drive 100 miles on the freeway. We all have those thoughts, but I always say, no, there's consequences to that. I would hate myself if I did those things. I would hurt the people that I love. I could get hurt or hurt somebody else. So a lot of times, again, those stoppers, those blockers, those things that say stop, that's not a good idea, are not functioning correctly. Next slide. Impulse control problems. So this is a big one. It's oftentimes that hypersexuality, right? Where we're thinking about sex a lot and we can't stop thinking about it. We can't suppress those thoughts. Or we think about shopping, all of the things that we want to buy. And you could see how we could very easily get caught up in this cycle of we don't have enough dopamine. Buying something naturally gives us that rush of dopamine that we want. Having sex gives us that rush of dopamine that we want. Eating a gallon of ice cream gives us that rush of dopamine that our brain and our body are so desperately craving, coupled with the fact that this break isn't working. So you can very easily see how we would get into these problems where our body is saying, give me dopamine. And we know these things will naturally release dopamine in our body. And we're not thinking about the consequences. Next slide. Executive functioning helps us differentiate amongst competing thoughts. So maybe I told my son or my grandson that I would go watch their baseball game today, but I don't feel good. Which one am I going to listen to? I promised him I would go. He's expecting me to go. People will be mad at me if I don't go, but I just really want to sit in my recliner and watch TV. How do we combat those conflicting thoughts? How do we determine what's good and bad, better and best, same and different? How do we think about the future consequences of our activities? So maybe you have a physical therapy appointment, and this would come up with my grandfather often. He knew he had the appointment, but he didn't feel like going. So a lot of times he would say, I'm not going, cancel the appointment. And we would have to say, no, you can't cancel your appointment. You need your physical therapy. You know you'll feel better afterwards. You can't set the example that you can screw your commitments and just say, I don't want to do it anymore. And then he'd say, oh, I never said I wasn't going, I'm going. And sometimes you need someone else to remind you of why you're doing that committed action, even though you don't feel like doing it in the moment. Next slide. Apathy is a big one. So that sense of, my partner would be fine if he sat in the recliner chair and watched TV. He doesn't care to go out. He doesn't care to see people. He doesn't care to go to appointments. He doesn't care to do anything. And again, that executive functioning is what helps us stay connected to our values, to what gives our life meaning and purpose. A lot of times we are content being in our living room, in our own environment, where we know we can get to the bathroom, we know where our medication is. The idea of getting out and going somewhere new feels so overwhelming that a lot of times we just don't feel up to doing it. So a lot of times I hear from spouses, should I push them to go? Should I accept their no? I know they'll feel good after they go, but I don't want to fight with them again. And there's this constant pool of knowing how much to push, knowing it's good for them, and how much to just say, fine, because I don't want to take on that battle right now. Next slide. Visual spatial functioning. So that was executive functioning, the visual spatial functioning. This again is helping us be able to navigate in our environment. So there are eye cells in our eyes that need dopamine to function correctly. We used to think it was just that motor part of our brain that needed dopamine. And now we know every part of our body needs dopamine. Our eyes need it, our stomach needs it. When we don't have it in our stomach, that's what causes us to have that constipation, that lack of digestion. Things just sit in our stomach and don't pass through us. Similarly, our eyes need dopamine. So a lot of times people will feel like they have double vision, or they have floaters, or their depth perception is off, or next slide, they feel like this coat hanger from a distance can look like a person. It's not a delusion or a hallucination. It's a visual misidentification. Oftentimes when we're in a dark room, we can see shadows on the wall, or we can see things darting across the floor. And this is a combination of, again, our eyes and also that brain function and being able to do that reality testing. Next slide. Information processing speed. So we talked about how just like a person's body moves slowly, their brain can process information more slowly. And we're slower in formulating our sentences. We have that reduced reaction time, and we're slower to respond. In no way does it mean we don't care. Just give us extra time. A lot of times when I see couples come into my room, the person with Parkinson's will kind of defer to their partner to answer all the questions because it's easier for them, or they'll just like look to them like, you answer the question on my behalf, because it's hard to think about it and come up with the words. And just like sentences automatically come out fluidly for most of us, when you have Parkinson's, you're thinking about each word and how to formulate the sentence, and it's not automatic. So it makes sense why you would ask your partner, who could do it so much more quickly and eloquently than you, to answer the question. But it's important that we maintain our voice, literally and figuratively. Next slide. So dopamine affects our cognition, it affects our behavior with the apathy, with the anxiety, with the depression, with the lack of initiation to get going. It also affects us emotionally and our movement, of course. Next slide. So cognitive mimics the motor, right? We are slow physically, we can also be slow cognitively. Getting stuck. Sometimes when people with Parkinson's walk, they freeze, right? That same phenomenon can happen in our thought process where we're thinking about something and then boom, it's like we hit a mental wall or a cognitive freeze. And it takes us a second to get going again. Rigidity. So just like we can be stiff in our arms or our legs, we can sometimes be cognitively rigid. And that can look like stubbornness, or it can look like irritability. That cognitive flexibility helps us sort of loosen up mentally and be more flexible and more easygoing. Sometimes we can get stiff with just not wanting to do certain things. And then just like our body experiences that fatigue, our brain also experiences that fatigue. So again, we need breaks. Maybe just let yourself do something for 10 minutes instead of 30 minutes, or let yourself disconnect and lie down and give your brain a chance to sort of recuperate. Next slide. So the facial masking oftentimes can cause problems. So we know that we experience that stiffness and slowness in our face, and people can misinterpret that, right? They think we're mad, or they think that we're not interested. And again, it's not true. What you're seeing on the outside is not always an accurate reflection of what we're feeling on the inside. But the facial masking, coupled with the not being really verbally expressive anymore, it can make a person seem like they're kind of put off or not wanting to engage. And a lot of times I'll hear from partners, they'll say like, my loved one doesn't care. And I'll say, have you asked them if they care? Well, no, but I can tell by looking at them, the nonverbal communication. But if you ask, do you care? They'll say, of course I do. I wouldn't be here if I didn't care. And sometimes we forget how much energy something requires. And we're not giving the person with Parkinson's credit with how much they're showing up and how much they're doing and how hard they're working. So again, it's not like the person with Parkinson's is wrong or their caregiver is wrong. Both of them have really valid points. And my job as a psychologist is to help them understand where one another is coming from. Next slide. One really interesting thing that I have found is this disruption in that internal rhythm. People with Parkinson's oftentimes say that they feel really uncoordinated, or even with dancing, we have that rhythm within us. And sometimes they just feel clumsy or like they have two left feet. Also, there's that internal rhythm inside us that gives us the sleeping pattern, or the just feeling like our body is in sync with itself. Sometimes it just feels like I have disconnected body parts and it's not operating as one. Next slide. I oftentimes hear my patients say, I just don't feel well. And I'll have their family say, what do you mean? What's wrong? Is it your back? Is it your leg? Is it your shoulder? And we're trying to figure out what's going on. And sometimes a person just feels crummy. There's that general malaise. They just don't feel well, but they can't identify a specific thing that it is. And that can be hard for the person who wants to make it better for them. And I think it's so important for the family to understand sometimes they just feel shitty and they can't tell you why. And you just have to understand their body is going through a lot. Their body is lacking those chemicals that it needs to feel well. So pain and discomfort and just feeling down is a very common complaint that I hear. And sometimes spouses say, oh, I thought he was just being difficult. And we forget what's going on in their body. Next slide. Another thing I hear from families all the time is it's so hard with the fluctuations. Sometimes the person with Parkinson's is doing great and they're engaged and they're optimistic and they're moving good. And then the next minute, all of it is shut off. They're feeling off. Nothing's working right. Cognitively, they're in a daze. They're feeling anxious. Their body's not cooperating with them. And it's so hard to make plans to say, I'll commit to going to that party because maybe you were having a good day and you can go. Or maybe you wake up and everything's wrong. Your bladder's giving you problems. You have a headache. You feel nauseous. You feel weak, and it's not a good day. And it can be so frustrating to say, should I commit to the plan? Should I not? Should we play it by ear? I don't want to feel like I'm canceling all the time. And again, that's where that cognitive flexibility and that emotional flexibility is so important, to say, you know what? If you want to go, we can go. And if you don't, that's okay. But that's hard to be able to do that. When the Parkinson's medication wears off, oftentimes our cognition goes down, right? And our anxiety goes up. So sometimes I can feel my patient's medication wearing off in the session. They come in and they're very with it and alert. And then it feels like I can slowly see them turning off. And it can happen within an hour, or the opposite happens. They come in off, and then I slowly seeing that medication kick in. So those fluctuations can be really frustrating for both a person with Parkinson's and their caregiver. But I think it's important to know it happens to all of us. I think people with Parkinson's are very prone to feeling shame and feeling guilt and feeling like they're not only missing out on life themselves, but now you're making your partner miss out on life. And it can very easily turn into this really depressing thing. Next slide. Another thing I hear from family is, my partner doesn't want to talk to me. He doesn't engage me. He just wants to sit in his chair and be left alone. And then his brother calls. And then all of a sudden he's Mr. Chatty and he wants to talk about sports and he turns on. And I'm like, so you just don't want to talk to me, but you'll talk to him. And I think it's really important to remember that different people bring out different circuits in our brain. So I think it's important to not take that personally, as easy as that sounds, but remembering that different settings elicit different feelings and different people elicit different brain circuits. It's not that they love their brother more than you or like talking to them more than you, but it's different, right? It's a rare occasion to get to talk to whoever it is. So sometimes care partners can feel like they can turn it on when they want to. And I think it's important to remember it's different parts of the brain are being activated. And of course, they would want to be on all the time if they could be. Next slide. I hear from families all the time. Is it John? Is it the Parkinson's? Is he just not trying? Is he being manipulative? Is he faking? Is it genuine? Is it authentic? And it can be very confusing to know what appropriate expectations are for your loved one. I think they're being authentic. We just can't see what's going on inside of them. But it can be hard to know, should I push them? Should I be mad at them? Where's the personal accountability? Can they be responsible, or is it just outside of their control? And it's always evolving and changing. And it can be hard to not be able to know what to expect from one moment to the next. Next slide. How to prevent or slow down cognitive decline. How are we doing on time? I didn't set my timer this time.
It's 11:20. So we have about 10 minutes.
Okay,
left.
perfect. All right, next slide. So people often say, what can I do to help my cognitive ability? The number one thing is to be physically active. Above everything else, if you can increase your physical activity to whatever level is safe and feasible for you, that's the number one thing to do. We oftentimes underestimate what a walk, whether that be on our own or with a walker or even in our wheelchair, outside can do. Getting that direct sunlight into our eyes can do wonders. A lot of times people will sit outside and they'll say, take off your sunglasses, because our eyes need that direct sunlight and it incredibly boosts our mood. So sitting outside and being active are super important. The number 2 recommendation I would say is reducing cardiovascular risk factors. So exercise will help with that, as well as diet, eating less processed food, eating food that's nutrient dense. So the more we can manage those cardiovascular risk factors, the better it is for our brain. There's a very strong connection between our heart and our brain. If we help our brain, our heart, then it inadvertently helps our brain. And then the third one is managing your medication. So taking your medication on time, knowing if there's any contraindications for your medication, knowing the side effects of your medication, really getting a grasp on what your medication regimen is, even though it can be hard to know all the medications we're taking. And to manage our pill box. So one of the cool things about the home-based primary care program is we have a pharmacist that looks at every patient's medications and sees what can we remove, which one can we substitute for something that won't increase their cognitive impairment or put them at risk of falls. So managing the medications would be number 3. Next slide. Staying socially engaged. So a lot of times, like I said, we're comfortable in our recliner, we want to be alone, but social engagement has a lot of benefits on our overall health and what's been the most helpful thing you've learned about Parkinson's?
Just fight one day as you can, and one issue at a time, and don't become overwhelmed, because it's not going to be easy, but join with your brothers together and talk about it. That's the best thing. Don't be one of those people that just frustrate yourself and not share. Talk to people about your problems, and talk to your family and friends.
What would you tell your fellow military veterans who are living with Parkinson's?
It's going to be a long road, and take one issue at a time. Things are going to pop up, and don't give up. Don't give up hope, because there's a lot of research being done, and don't get frustrated that when you tell people you have Parkinson's, they're going to look at you like you have 3 heads. And even people in the field, unless they've done a fellowship in Parkinson's, they are not going to totally understood, even if they're in neurology. And so don't give up hope, and try to improvise, and try to organize your issues, and understand what you're up against. Take it as a military issue, and don't give up hope, because there is going to be more developments in this field. And so take it slow, and don't give up hope. It's going to get better.
I love that. Take it as your mission.
Yes.
The next challenge.
That's right.
Do you feel a sense of camaraderie with the VA Parkinson's group?
Absolutely. And the nice thing about this is we're in it together. And so the support the VA has given me has been tremendous, and I can't ever repay the VA. I thought, well, I struggled, and I have a lot of medals, and I did a lot of things I felt were brave, and I don't know if they were, but they have given me back more than I have ever given this country. So I thank you very much, VA. You've given me so much, and I want you to, my heart is out to you. The VA is great, and the camaraderie is terrific, and let's pull together. And if you can join any group you can, reach out and try to get together with a small group or a larger group, but particularly a smaller group of Parkinson's people, because that's the best thing you can do is reach out and feel the togetherness and the tightness of fighting this together. That's the best thing you can do.
All right, so we talked about being physically engaged, and people often ask me, what's the best exercise I should do? Should it be cardiovascular? Should it be weight training? Ideally, it'd be both. They say, should I box? Should I dance? Should I do ping pong? Should I do running? And it's whatever you enjoy, whatever you're most likely to actually follow up and do is the one that you should do. I don't think there's one size fits all. I think do what you have fun doing. Next slide. And that goes into the next one of being cognitively engaged. People say, should I read? Should I do crossword puzzles? Should I take up a new hobby? Should I play an instrument? Should I learn how to knit? And again, it's whatever you're going to enjoy and whatever will cognitively stimulate you, and you'll have fun doing it, whether it's listening to music, whether it's doing trivia games, whatever you enjoy doing is the one that you're going to get the most benefit from. Next slide. What activities do you do to keep yourself cognitively engaged?
I do online. AARP has a bunch of games and crosswords. I try to do the Sunday Times, New York Times crossword. I can get up to maybe Tuesday in the increasing difficulty, whereas I used to be able to do Thursdays. But I'm at Tuesday now, so that shows a decline right there.
Yeah, I saw some books on your desk. Are you still reading to keep yourself cognitively engaged?
Well, I try to read, but that's difficult for me because I need a magnifying glass and bright, sunshiny windows. But I get books on tape, audio tape.
And the last one is staying spiritually engaged. I think whether you're religious or not, being able to connect with something that gives you meaning and purpose is so important, whether it's being a grandparent, whether it's volunteering, whether it's giving a financial donation, whatever it is that makes you feel like you're contributing. Because if you're bedbound and if you can't talk, there's still things that you can do to contribute. It doesn't matter what you're physically able to do. You can give words of encouragement to somebody else. And I think having that mindset of gratitude is so important. No matter what your situation is, you can help somebody else. Next slide. I oftentimes wonder what it is about people with Parkinson's that I like so much. Why is it that I love my sessions with these people? What is it that I want to be friends with these people? And I have just qualitatively come up with a lot of these traits that I see in patient after patient after patient, that a lot of them are very responsible and conscientious, hardworking, have a keen sense of humor where I don't expect it, and they will say the funniest thing. And sometimes it's with a straight face and a monotone voice, but it's so funny. And a lot of them have very good BS detectors. They can see who's the fake person and who's the real authentic person. And I like that. Very wise, very observant. Oftentimes don't need to be the life of the party, but if I go sit next to someone who's sitting at a table by themselves, I find that this person is fascinating. And if it were someone else, that they would be bragging about all the things they've done, but usually they don't need that. They're confident with who they are and they don't need to toot their own horn. They're internally motivated, and a lot of times they had to grow up fast. They didn't get born with a silver spoon. They weren't handheld. And it's just amazing to see how resilient and what they've done. They're oftentimes even keel, and it can be hard for them to receive compliments. Sometimes they get uncomfortable, but again, very resilient. And I think it's important to remember who you are and all of the strengths that you have. And you may feel like you don't have anything to contribute, but when people get to talk to you, you have so much to share. Next slide. With that, there's the 3 I's, which one of my patients told me: the loss of independence, the isolation, and the loss of identity. We won't get into too much of that today, but these are a lot of the themes that I work with patients around. Next slide. Coping. It can be really hard to learn how to graciously become dependent on others when you wanted to be self-sufficient from a young age and be independent. And that was your sense of identity, being the rock for everybody else, being the stoic, strong one. And now you feel vulnerable, like you're constantly having to be embarrassed and be the one who's always needing the help when you never wanted to be a burden on anyone. Oftentimes I hear people say, I'm just sick of hearing myself complain. But it is. There's so many different things that you're managing. And I don't think it's complaining. It's we can't fix what's going on unless we know what it is. And a lot of times it's about preparing for the future, right? And having those moments in the day where you feel like I had fun, I had a good laugh. That was a good time. And being able to have that in the day is really important. Next slide. We talked about the complexity of Parkinson's being an onion, and no one can definitively tell you what to expect next. People also oftentimes say, well, when will it get bad? Or when do you think I should prepare for this? And it's so hard when everyone's symptoms are different. Everyone's progression is different. We know we all have our own stories about how we got misdiagnosed, or somebody kind of brushed off our initial symptoms, or we had to go through the runaround to actually come to our Parkinson's diagnosis. And I think as you go on your Parkinson's journey, it's a lot of that. People will dismiss you, people will tell you the wrong information, but you know yourself, and you have to trust what's going on within you and advocate for yourself. Next slide. Oftentimes in therapy, I help people identify when they're feeling resentful of other people, when they're being critical of themselves, when they have guilt over the past, and when they have an abundance of fear over the future. I think that dis-ease can create disease. And so acknowledging what you're thinking, what you're feeling, expressing it and putting it out there is so important. And that love, joy, and forgiveness are the healers. And a lot of times it's that forgiveness of yourself. Next slide. I kept thinking as I was preparing this talk, they don't really care about the cognitive stuff. They just want the hope. And I think we all need to feel that hope, like there's a reason to put that one foot in front of the other. Like I'm not in this by myself. There is a reason to keep going. And I hope that what you walk away from this is not necessarily knowing every cognitive domain, but that you walk away with a feeling of hope, knowing that there's people who are working to make your quality of life better, and knowing that you don't have to do this by yourself. Next slide. I think if we can just skip to the very last slide for the sake of time. These are just strategies for helping to keep yourself organized and on task. This is a website for the National PADRAC, which is the Parkinson's VA website. For those of you that have Parkinson's and were exposed to either Agent Orange during Vietnam or the Camp Lejeune water contamination, there's a possibility that you could get service connection if you have a diagnosis of Parkinson's. It used to just be Parkinson's, but now they have opened up the criteria to be Parkinsonism, which is all of those umbrella Parkinsons that we talked about initially. So these are just a couple great websites. And the next slide. We know that the Parkinsons Foundation put on this event for us today, and they have a host of resources. And then here's a variety of ways to connect with the Parkinsons Foundation, with the VA. And also I want to just touch upon this last one, which is the caregiver support program. We know that Parkinson's does not just affect the person with Parkinson's, it affects the entire family. And so we can't take care of our person with Parkinson's unless we first take care of ourselves. So there's a lot of resources through the VA for caregivers. And then lastly, the people that I want to thank, my colleagues at the VA. It's not a job that I can do on my own. I have wonderful colleagues, whether that be nurses, the primary care providers. We had Gladys, the KT, we have pharmacists, we have social workers. We have all kinds of people that are there to help people with Parkinson's. I want to just thank my mentors and past supervisors, the Parkinsons Foundation, everybody that came together to make today's event a success. My patients, everyone in the Parkinson's support group, and their families. My family, you can see my two little ones here. Lila is 5 and JJ is 1. Also my husband, who's also a clinical psychologist at USC, who will be answering some of the questions with me up here in a second. And then also my mom, who helped get us this venue here. It was my mom's dad that had Parkinson's. So it's a family affair. We all work with people with Parkinson's and know firsthand what it's like day in and day out. Also Chloe, who's our DJ for today. Thank you for being here. Gladys, who led us through the exercises, and then the 2 veterans who graciously were able to do videos with me. Brett, who's an astronaut. He's a literal rocket scientist, and Tony, who is just garnered in all of these medals and is a real war hero. So they have Tony and Brett have an amazing friendship and are very competitive with each other about who's cooler, but they're both super cool. So that's it. Thank you so much.
Thank you, Megan. I'm gonna invite Megan to stay up for just a little bit of Q&A. And then I'm also going to invite Andrew Petkus, PhD. He is a clinical psychologist who currently practices at Keck Medicine of USC. So dynamic duo. Let's get them both up here. Oh, thank you.
Sure. Not good?
You too?
Yeah.
Okay.
Okay. All right. And yeah, we just have time for a few questions. If you have any questions and you wrote them on a card, if you don't mind just holding your hand up, and Bernice and Lauren will grab those, and we can sort through those. Also, if you are online or in person and you didn't have your questions answered today, please call our helpline after. They are amazing. I've called them. My brother has Parkinson's. I've called them several times to ask questions. Please give them a call, and they can refer you to resources. They can send you, I'm sorry, I keep forgetting to take that off. They can send you to support groups, exercise classes, and so forth. Okay, I'll get started here. A lot of the questions were really asking about how to access these services. Those are most of the questions we got in the chat. I know we showed some resources, but do you have sort of just a suggestion on how to get started accessing these resources through the VA?
Yeah, I think a lot of them are referrals from your primary care provider. So they can put in the consults for speech therapy, for physical therapy, occupational therapy. At the Long Beach VA, we have yoga classes, we have Tai Chi classes, classes, stress management classes. They can put in the referral for the psychologist. So I think starting with your primary care provider, and also just doing your own research, because there's like massage therapy, there's the chiropractor, there's acupuncture, there's aquatic therapy, there's a lot of things that aren't advertised. And I think if you go to a support group, oftentimes you learn more from the other veterans than you do from any of the doctors, because they're the ones that share resources and share how they sort of got to the resource gold mine that they have. So I think talking to other veterans will get you a lot further than talking to some of the doctors.
Fantastic. Is the sound okay, guys? I just wanted to double check. Do you need us to do anything? Okay, got it. Okay, just making sure everyone can still hear us. Okay, so we did have a question, and I don't know if this, Dr. Petkus, one of your specialties in research, I believe, is anxiety and depression. Can you explain to us how those are associated with cognitive decline? We had a question about anxiety in particular and treating anxiety as part of cognitive decline.
Right. So there's a lot of research showing that anxiety and depression and stress are not very good for your cognition, that they can impact cognition right in the here and now. So when we're feeling very anxious and stressed, I like to describe it as kind of like we have a gas tank of cognitive ability, right? So like we have so much energy that we can put forth to whatever cognitive task is in front of us. And if we're feeling anxious, we're worrying kind of about bad things that might happen, and it's kind of like punching a hole in that gas tank, and that we're wasting a lot of our cognitive energy kind of goes away or gets siphoned away. If we're worrying about things, or if we're depressed, then we often are thinking about things that have happened in the past, or wishing about the way things that we wish would be the case right now. And then those thoughts are kind of also sucking away our cognitive energy. So in the here and now, those things can impact us negatively in the present, but also there's some thought that people and that feeling of the changes in the chemical reactions that occur in our brains when we're feeling anxious or depressed can be bad for our brain health and can contribute to changes going forward. So I think managing anxiety and depression is really important. And the good thing is that there's a lot of treatments out there, both pharmaceutical treatments, so medications that can be helpful for managing anxiety, depression, but also psychotherapy and different types of counseling can be helpful as well.
Great. We had a couple questions about the symptoms, cognitive symptoms changing throughout the day. Is that common, that symptoms seem to be better or worse throughout the day?
Yeah, so I think,
Okay, thank you.
okay.
Thank you.
So I think that there is evidence that there could be fluctuations throughout the day, especially related to a couple of things. So like oftentimes we might be more alert or have less fatigue in the morning. So when we're feeling less fatigued, our cognition's typically better, but then oftentimes in the afternoon we might become more tired, especially like what Dr. Gomez was describing very clearly and great during her presentation about like that executive function kind of, and that decline in executive function could make simple things that used to be kind of automatic and simple be more tiresome. So like at the end of the day, our brains can just be more tired, and therefore they can kind of fluctuate throughout the day with that, as well as medication factors. So I know that there's a lot of literature suggesting that when they get the end of a dose of when your medication starts wearing off, that there is cognitive changes, that people's cognition tends to be better when the medication is fully on and working. And so that could also be a very important contributing factor.
Wonderful. Oh, thank you. Okay. Then we had a question about, finding the right doctor, I think is what this question is about. If you have a doctor who maybe you, like a neurologist, who maybe you feel isn't, you mentioned it's in and out, right? You're 15 minutes in the appointment and then you're out again. How important is it that you find someone I don't know how to phrase this, because this is, we don't want to hurt their feelings, or seem demanding. But the dad's health is more important, right, than the feelings. Can you talk us through this relationship of finding the best doctor?
Sure. I guess I could take this one. So I think that's super important. Whoever you're seeing, you want to feel like they're listening to you, and that you're understanding everything. So finding the right doctor, I think, is really important. I know one thing, I think what Dr. Gomez was saying also, that and what was brought up, I think, by in one of the patient discussions, is that finding a movement disorder specialist, I think, is really important. So finding someone who specializes in Parkinson's disease, but also, I mean, if that person isn't working out for you, I think not being shy about trying to find somebody else. I think, because I mean, your healthcare is your healthcare, and if that provider isn't working out, I don't think it's a bad thing to kind of pursue somebody else.
Yeah, I think
Yeah.
feeling comfortable with your movement disorder specialist, ideally, is one of the most important things. I think it's okay to try several different doctors until you find one that you feel like is listening to you and able to give you something that's helpful. I think so often we can walk out of an appointment and feel discouraged, feel like we didn't get listened to, feel like we're walking away with more questions and answers. And there are some really good movement disorder specialists. So I would say, don't settle, just like anything in life, don't settle until you find a doctor where you feel like we are in sync and they get me, and I'm walking out feeling empowered and I know exactly what the next steps are for me.
That's hard. I'm not a doctor. Most of us aren't. So it's important, though, to remember that. So thank you for that. We had a question from our in-person audience about dental health and mental health. Is there a connection? Dental and mental.
Sure.
Yeah, I think it's a great question. There is definitely a link. I think the inflammation in our mouth is indicative of the inflammation in our brain. So I've actually spoken with several dentists about this, because I feel like when people lose teeth or when people have inflamed gums, inflammation doesn't necessarily happen in just one part of our body. It's oftentimes a systemic issue. And so I think our oral health can tell us a lot about what's going on in our brain. So I think a lot of times we neglect our oral health, and just like there's that strong connection between the heart and the brain, there's a strong connection between our oral health and our brain health. So if there's inflammation in our mouth, there's inflammation in our brain, and figuring out what's causing the inflammation. Is it stress? Is it diet? And trying to minimize that inflammation is super important.
No, I think you described it pretty well. This discussion about the inflammation in your mouth can be suggestive of inflammation elsewhere.
Yeah, and I think a lot of patients with Parkinson's have oral health issues. So yeah, again, it feels overwhelming. Now I have to worry about my mouth too, but yes, it's all connected.
Thank you so much. This will be our last question, and then we'll wrap. I just want to thank everyone again for staying with us. How often, what is the sweet spot for cognitive evaluations and tests during the course of the disease? And this person kind of wanted to know, because they were asking, does the person recognize they're declining? Do those tests help with that? And, should the care partner be involved in those? Or it almost seems like there's a spot where maybe it's a little too much, or maybe it's not enough. What is the best?
Yeah, I think it's a great question. I'll defer to Dr. Petkus. This is one of his areas of expertise, neurocognitive testing with Parkinson's.
Well, before I get into that, I want to also just say thank you for letting me be part of this great event. It's really great being here. And as Dr. Gomez was saying, yeah, so at USC, my role in the Division of Movement Disorders is conducting neuropsychological evaluations with people with Parkinson's disease. So that's a really great question. And I think One of the things that I think could be helpful is trying to get especially if you're concerned about your cognitive ability, getting a neuropsychological evaluation can be very helpful because it can kind of lay out about kind of how you're doing and establish kind of a baseline of how you're doing and identify and the big part of the neuropsychological evaluation is providing those recommendations. So like, what are some of those recommendations of maybe things that you can change in your environment to kind of set you up so you're playing to your cognitive strengths, and then your environment is also set up to kind of compensate for maybe some of those changes that might be occurring to the thinking abilities that Dr. Gomez was saying. So in terms of when to get a neuropsychological evaluation, I think especially if you're feeling or noticing some changes, that earlier on can be very helpful to kind of see, get this baseline. So then in the future, you can have that evaluation to compare yourself to. But yeah, I know the neuropsychological evaluation is really important, but it can be also a source of stress for some people. But I don't know if you have anything else to add.
Yeah, I think it's one of the ways that you can get objective feedback. You have your perception of how you're doing, and those that are closest to you have their ideas of how you're doing. But it can be helpful to do these standardized tests, which have been given to thousands and thousands of people. So we know, how are you comparing to these other people? Oftentimes the neuropsychological evaluation can be like 4 hours. So the person who's with you is really getting a sense of how your brain is working. And it's a very individualized plan that they can come up with for you. And it can really be a roadmap for knowing what to prioritize, what to focus on, and really how to best use your resources. What's going to give you the biggest bang, and what to focus on.
That's great. That's a good note to end on.
Mm-hmm.
So I just, I'm going to pop back over to the podium here because I want to do the thank yous. This is an important part of the program. Thank you everyone for being here today in person, and thanks to everyone who's online. There is going to be a brief survey online. You'll see it pop up. And there's also one on paper here. It's in your packet on your table. We'd love to hear what you think. Give us your feedback. This is how we plan our future programs. We want to thank Dr. Gomez and Dr. Petkus and Gladys Yu. We also want to thank again Lori Guion, the Office of Supervisor Janice Hahn, and then the City of Paramount, again, for their generous assistance with the program. And thank you, of course, to our sponsors, to Boston Scientific, Supernus, Accorda, and Abbott. Thank you all so much for being here today. Today's session was recorded. It is going to be archived on the Foundation's YouTube channel in a few weeks, and then a link will be sent to you just as another reminder. If you had a question that didn't get answered, I know there were a lot, please do reach out to us. Call that 1-800 number. The folks on that line are amazing. You can also email, if you prefer that, helpline@parkinson.org, and you can order any of our free resources that way as well. Many, many thanks to all of you for attending, and stay safe. Thank you.